Lots of things go into making sure that these pills in this container are safe and that they actually work. But there's been a lot of things over the years that have shaped drug policy and drug regulation, both in Canada and across the world. One of the problems historically is that sex and gender factors have been excluded from research. We're starting with a very limited evidence base to begin with. But then, more to the point about these drugs, they haven't been included in the regulatory steps that actually check what we're getting out of Health Canada. There's been some catastrophes in the past, especially in women's health. One, for example, was thalidomide, a drug that was prescribed for nausea in pregnant women that resulted in all kinds of birth defects and shortened limbs in their offspring. Over the years, policies and pharmaceutical development has begun to take into account some of the responses to these kinds of devastating events, but we still have a long way to go. Including sex and gender and other equity factors, in particular age and race, into the analysis of prescription drugs long before they get to the market, has an impact on our health more generally. If we want to have personalized medicine or precise health care that's really built for us as individuals, then it's necessary to take a close look at issues like sex and gender. The other thing we have to look at with drugs is whether or not males and females have the same responses to them. And we find that they don't actually. And then finally, it's crucial in our view to make sure that consumers and clinicians like you end up with the knowledge and the information about whether or not that drug is right for you. So, how are drugs managed in Canada? There's a long regulatory process that is circular and it's rigorous and it builds on the previous step. First, there's preclinical trials where drugs are tested in animals, in experiments, and these are studies to start to try to understand how a drug reacts in a body and what kind of dosage is required and whether or not it's safe. There are various phases of clinical trials that are conducted, each one escalating to begin to involve humans and to begin to try the drug in wider and wider populations. And these are all aimed at trying to figure out if the drug is safe, if it works, and what the right dosage might be. This is a pretty rigorous process. We're looking at risks and benefits, and once it's complete, a new drug submission can be made. And what that means is that a manufacturer can then apply to Health Canada to get approval to take a drug to market and sell it. Once that drug is on the market, the post-market pharmacovigilance begins, and that means monitoring the safety of the product. So in that phase, we're looking for reports of adverse events, and we want to monitor them and see if safety is a concern and for whom. And if safety is a concern, then those drugs can eventually be removed from the market. In Canada, the reporting of adverse events has been mandated. This is called Vanessa's Law, which mandates all hospitals and medical institutions to report adverse events. And furthermore, they have to report the age and sex of the person who experienced the adverse events. But even so, adverse events continue to be underreported. A body may, in fact, respond differently to a drug than the next body. So males versus females, different races, and certainly different ages of people react differently to drugs. Unless we do this kind of pre-work in the clinical trial, in the evidence that we derive from research, or in the adverse event reporting, we don't have a full picture of how women's health is being affected. We have a process in Canada called Sex and Gender-Based Analysis Plus, and we applied that to this system in Canada to try and figure out what had been going on and what could be changed. And we found, not surprisingly, that a lot of drug development has used the male body as a norm. We also found that the precautionary principle has prevented women, especially pregnant women and lactating women, from being included in clinical trials. So we've ended up with inadequate science. Decades of advocacy, primarily by women's health activists, has tried to change this to get more women involved in research and more women reporting their adverse events to the government so that that database of adverse events is built up so that we have a much better understanding of what goes on in women's health. There's a bit of a disadvantage if the evidence is not there underpinning the drug development, so we don't have a full picture. So we want regulators to look at issues like hormones, genes, anatomy, physiology, metabolism. These aspects all affect the pharmacodynamics of what goes on when a drug enters your body. How is it metabolized? How is it distributed? And how is it eliminated? We also want the government to take into account gender issues. How do gender roles, expectations, relationships affect the kind of prescriptions we end up getting or that we end up wanting? These aspects are very under-researched. Using sex and gender-based analysis plus recognizes that both biology and the social experiences we have in life, as well as other intersectional factors like age, which is developmental, interact to provide the result or produce the result. We found that there were real deficits in all of these areas about integration into clinical trials, integration into the research. We find that different groups of people, whether they're women, men, low income, high income, young or old, are less or more willing to go into a clinical trial. So often the research in the clinical trial phases are not necessarily reflecting the distribution of people who are going to end up taking this drug. And that's important. We want to have more women included in clinical trials. We want a more robust adverse event reporting system. And we want more research that is focused on looking for not just sex differences, but sex-related factors affecting things like safety, efficacy, and dosage that stem from things like organ size, metabolism, or hormones, or genetics. Canada has this exciting opportunity to be a leader in this area, in part because we have a sex and gender-based analysis plus policy, and we have applied that to prescription drug management in this particular report. We also have the opportunity of using the expertise of the new Scientific Advisory Committee on Health Products for Women, which is mandated to look at both drugs and devices and how they have in particular affected women over the years. So it's really interesting that we don't know what we don't know in this zone. And that's a really key thing that we have to understand as a country to try and figure out how to rectify it. Because until we rectify it by integrating goals of equity, diversity, and inclusion, and sex and gender-based analysis into all of the regulatory processes, we won't get to the point where drug use is as safe and as effective in every citizen, which is where we want to be.